Invite the chairperson of today's CME, Professor Dhruva Chaudhary sir, who is a professor and head of pulmonary and critical care medicine and professor in charge of research at UHS Rohtak. He is also the member Lancet India Task Force on COVID-19, President Association of Commonwealth Scholars and Fellows. He is a state nodal officer of Haryana for COVID-19. He is a past president of Indian Society of Critical Care Medicine. He is the ex-dean medical super specialty UHS Rohtak and also the ex-dean student welfare. He is also the ex-vice chancellor, Indian College of Critical Care Medicine. I would like to hand over the session to Dr. Dhruva Chaudhary, sir.
Thank you, Preeti. I think in the interest of the time, I will invite Professor Tyagi. We have been, as a student also, when sir was at Pant, we have been looked up to him. Especially, sir, I do remember your aortoarteritis and renal artery stenosis. And Professor Tyagi has been a former Director General of Health Services, Government of India. He has been the Dean of Maulana Azad Medical College, New Delhi, has been Director of GB Pant Institute and has been President of Cardiology Society. He also is the recipient of BC Roy National Award. I think he has a huge number of laurels which will be difficult for me to count. But I know when we were postgraduate students, I'm talking of late 80s and early 90s and the postdoctoral fellow, we always used to look up to him, especially when we worked with Professor B.K. Sharma at PJ Chandigarh with the aortoarteritis. I now invite Professor Tyagi, which is a very important topic of emergency medicine, acute chest pain, how to handle it and how to manage it. These words, Professor Tyagi, please.
Good evening, sir, for the kind words. First of all, I'd like to congratulate Professor Sareen for this wonderful initiative. I think this is a landmark in the history of the country, medical landmark, because the presentations, what we would be doing in today or the days after, would help not only millions of doctors who are working in this country, but the 140 crore people of this country, because they would be getting quality medical care by these teaching programs. So congratulations, Professor Sareen Sam. So I think today aptly he has chosen the few important emergencies which any of the physician or any general practice doctor would face day in and day out, and would be very important to distinguish what type of management should be given to those patients who come to their clinic with tremendous hopes of getting relief. The initial first presentation would be on management of acute chest pain. As you are all very well aware, acute chest pain can occur in a very large number of conditions. Today, I like to focus on the cardiac chest pain because that is the commonest type of chest pain, and you are already also very well aware that the cardiovascular disease are the leading cause of death in our country. So one should be aware about the diagnosis of acute chest pain and the common presentations and the management of acute chest pain. The serious conditions which cause acute chest pains are acute coronary ischemia, which is the commonest cause of this condition, which includes acute myocardial infarction, unstable angina. Even a patient with stable angina can present with chest pain. Another important emergency is aortic dissection, which is very important to distinguish from acute coronary ischemia, because the management of these two conditions is diametrically opposite. And pulmonary embolism, pneumothorax, and also pneumonia, which Professor Kilnani would be presenting subsequently, are very important conditions that can present with chest pain. Also pericarditis, which is another common condition which presents with acute chest pain and could go to any of the practitioners of medicine. Other causes of chest pain are also important, particularly like aortic stenosis, where the stenosis of the aortic valve these patients can present on chest pain on exertion, or patient with mitral valve collapse, hypertrophic cardiomyopathy also may present with chest pain. Another serious condition Professor Sareen would remember is esophageal rupture or Mallory-Weiss syndrome or cholecystitis, which are not uncommon in our country. Pancreatitis, a very common emergency in GIT, peptic ulcer and biliary colic, all can present with chest pain. Other musculoskeletal abnormalities like any muscle strain or any rib fracture or costochondritis is a common cause. Also, sometimes the chest pain may occur because of the spinal root compression or a herpes zoster during the initial phase, or post-herpetic neuralgia can also be presenting with chest pain. Coming on to the chest pain itself, the most important thing that I would be emphasizing on, that a very systematic approach is needed for the diagnosis of chest pain, because as my professor who taught me used to tell, that angina is a clinical diagnosis made by history. The investigation may often be normal. So a careful medical history is very essential in these conditions. Let's go forward. The description of chest pain is also very important. The type of chest pain, the quality of the chest pain, whether it is a diffuse chest pain, a compression type of feeling, the commonest presentation of the chest pain due to coronary arteries is not often chest pain, but a chest discomfort, which is often felt as a pressure type of sensation. Somebody is pressing heavily on the center of the chest. This can radiate to the left arm or the inner side of the left arm, or to the jaw commonly. And commonly, if it occurs on exertion and relieved on rest, this is called angina. But if it does not get relieved on rest and continues for more than 20 minutes, is severe and is often associated with diaphoresis, the sweating, and even sometimes nausea and vomiting. So may be confused with the gastrointestinal type of symptoms, and patient may just misunderstand this condition. The radiation of the pain and the progression that often the acute myocardial infarction progresses, the chest pain and the compression type of feeling, which I said can progresses. And what are the factors provoking this chest pain is also very important. What are the relieving factors? If you put a tablet of nitrate below your tongue and the chest pain gets relieved, this is a very important marker that this patient may be suffering from angina. The severity of the chest pain and associated symptoms, risk factors in this patient, whether it is a diabetic patient, elderly patient, or having a family history of coronary artery disease, are also very important. Physical examination can also aid in the diagnosis of the chest pain, as I shall be showing you subsequently. Particularly helpful is the electrocardiogram and the other tests like chest X-ray, echocardiography, and enzyme elevation is also very important modes of diagnosis of chest pain. This has been taken from recent publication of American College of Cardiology, published in 2022. This showed that the probability of ischemia is commonly based on the type of pain that is encountered. Like if a patient is complaining of a central pain, which is pressure type of pain, a squeezing or gripping type of pain, or there is heaviness on the chest, or there is tightness of the chest, these are very highly suggestive of ischemic pain. A retrosternal pain or stress-related pain is also very suggestive of pain. As compared to this, a short, fleeting type of pain, momentary pain lasting for a few seconds or less than a minute at a very localized position is often not ischemic pain. Any pain below the umbilicus or hip is unlikely to be myocardial ischemia. A patient may often confuse and get stressed because this may think to be of ischemic origin. Acute coronary syndrome often presents with shortness of breath, tachypnea, tachycardia, and hypotension. There is the sweating is also very common in those patients who suffer from acute myocardial infarction. Examination of the chest and may show that these patients may be having some murmurs, particularly mitral regurgitation murmur may be common in patients who have suffered from inferior wall myocardial infarction. Similarly, those patients who have pulmonary embolism could initially present with just dyspnea, and often they may be having high pulse rate, tachycardia, and because sometimes these patients present with pain with inspiration due to some pleural rub. Another very important life-threatening condition is aortic dissection, particularly in those patients who are Marfan syndrome. And in these patients, differential pulses between the two arms is very helpful in diagnosis of pain. This differentiation is very important because the chest pain may be severe, like acute myocardial infarction pain, and if this condition is properly diagnosed, the thrombolytic therapy, which can be disastrous if given in a patient with aortic dissection, emphasizing the role of diagnosis by simple physical examination is very important. Coming on to ischemic heart disease, the common type of ischemic heart disease, that is stable angina pectoris, that is that angina which occurs on exertion and is relieved on rest, is called stable angina. Next stage is of acute coronary syndrome, which is caused due to rupture of the atherosclerotic plaque. The initial manifestation may be of unstable angina or non-ST segment elevation myocardial infarction. I shall differentiate this in my subsequent slides, and the life-threatening condition of ST segment elevation myocardial infarction. Another important point here to remember is that atherosclerosis is a generalized process. It's not that you see a coronary artery with significant stenosis and that is the culprit. Atherosclerosis, in fact, is generalized within all the arteries of the body, whether it is the coronary arteries or the carotid arteries or aorta, or even in the cerebral arteries. All the arteries develop the atherosclerosis. So it is a generalized process. Another important thing to remember about atherosclerosis is it is an inflammatory disease. So commonly, the marked inflammation leads to rupture of the atherosclerotic plaque, leading on to unstable angina or acute coronary syndrome. To differentiate between these two conditions, that is unstable angina and myocardial infarction, is very important because the treatment of these two conditions is different. In patient with unstable angina, the myocardial necrosis does not occur as compared to patient with myocardial infarction. Because of the total occlusion of the coronary artery, the myocardium gets damaged, so there is elevation of the cardiac enzymes, that is troponin I or troponin T may be elevated. Also, CPK-MB is also elevated in these patients. The ECG is also helped to differentiate in these patients with unstable angina and myocardial infarction. In those patients with unstable angina, there are transient ST segment depression or T wave inversions, as compared to in acute ST segment elevation myocardial infarction, there is ST segment elevation. The differentiation is very important because those patients who have ST segment elevation myocardial infarction, they require of the measures to open the coronary artery and reperfusion, like in the form of thrombolytic therapy or primary percutaneous interventions. The risk of death is there in both these conditions. Unstable angina can also lead to development of myocardial infarction, leading because of the development of total occlusion. So the conditions, both these conditions are dangerous and have high risk of death. The pathologically, the unstable angina have partial coronary occlusions as compared to total coronary occlusion in patient with myocardial infarction. And the echocardiogram done shows that the echocardiographic ejection fraction may be normal in those patients with unstable angina, while those patients who suffer myocardial infarction because of the damage to the myocardium have developed left ventricular dysfunction or even right ventricular dysfunction, and there's because of this ventricular dysfunction, there are elevation of the NT-proBNP levels in these patients. The unstable angina is further differentiated, that those patients who have angina at rest, this is called rest angina. These are three forms of unstable angina: rest angina, new onset angina, and crescendo angina. Rest angina, as I said, is a prolonged angina, usually more than 20 minutes, but it is not accompanied by those changes of myocardial damage. The enzymes are normal at this condition. The patient who has severe angina but has a very recent onset of angina is also classified as unstable angina. Crescendo angina. Patient was having angina on walking up to 2 kilometers. Now, as the patient walks for 200 meters, he developed angina. That is called crescendo angina. That is also a form of unstable angina. And these are precursors of acute myocardial infarction because these patients have high potential of developing fatal myocardial infarction in the next 12 months. So they also have a high risk of death and myocardial infarction in these conditions. Coming on to ST segment elevation myocardial infarction, as I said, this diagram shows that the atherosclerotic plaque, as it ruptures, the atheromatous plaque comes outside in the endothelium. It attracts the platelets, and there is formation of a thrombus inside the coronary artery, which leads to total occlusion of the coronary artery. With the total occlusion of the coronary artery, the area of the myocardium distal to the coronary artery starts getting damaged, And as the time progresses, the more the myocardium gets damaged, and most of the myocardium gets damaged within first 6 hours. So it is very important to diagnose this condition within first hours and treat these conditions initially, because the first hour after developing of the chest pain of myocardial infarction is called the golden hour. Why it is called the golden hour? Because most of the deaths due to myocardial infarction, that is 50% of death due to myocardial infarction, occur in the first hour. And even if the treatment can be given to these patients within the first hour, most of the myocardium can be salvaged and patient can have near normal left ventricular function on follow-up. So important to identify this condition. So how to identify these conditions? The character of the chest pain is very important, and after diagnosing that this patient is having severe chest pain suggestive of myocardial infarction, patient should be taken up immediately for electrocardiography. And ECG is often in 80 to 90% of the patient, ECG shows that there are some changes in the ECG, but sometimes there may be no changes in the ECG despite the patient having typical chest pain. So it is also important to remember that those patients who have symptoms typical of acute coronary syndrome, even if they do not have diagnostic ECG in the initial evaluation, they should be kept in the for observation, and ECG should be repeated and enzyme should be repeated, because often these patients develop acute myocardial infarction in the subsequent hours and which could be lethal. These are the two acute coronary syndrome, that is non-ST segment elevation and ST segment. Very convenient to diagnose, because if the ECG shows elevation of the ST segment, this is ST segment elevation myocardial infarction, which this has the raised markers of myocardial necrosis. In those patients who have subtotal occlusion of the coronary artery, there may be only T wave changes and there may be no ECG, the enzymes may not be elevated. That is the condition of unstable angina. But if with this condition there is some elevation of the myocardial enzymes, then this is non-Q wave or non-ST segment elevation myocardial infarction. As I said, ECG is very helpful in after careful history and physical examination. ECG is the most important investigation in these patients. A simple ECG which is available everywhere in the country would help you to diagnose these patients very easily. In those patients who have ST segment elevation in their ECGs, the guideline directed management of ST segment elevation myocardial infarction should be done, as I would be showing you subsequently, very briefly though. And those patients who have the ECG does not show ST segment typical of acute myocardial infarction, but there is diffuse ST segment elevation with concavity upwards. In ST segment myocardial infarction, there is convexity upwards, while in patients with pericarditis, there is concavity upwards, and there is diffuse ST segment elevation in multiple leads, which I will show you subsequently. This is suggestive of pericarditis, and these patients do not require any of these medications like thrombolytic therapy or acute PCI in type of treatment, which is very important to discern in these conditions. Sometimes there may be non-diagnostic ECG or normal ECG. These patients should have repeat ECG if symptoms persist or if the troponins are positive. This has also been shown in the latest American College of Cardiology Foundation guideline, from which I have taken this slide. And in those patients who has typical the chest pain, but the ECG is showing normal, then lead V7 and V9 or the right side leads are taken to diagnose the right ventricular infarction or the posterior myocardial infarction. Sometimes the ECG may show the arrhythmias, whether the patient having ventricular tachycardia or other arrhythmias, which are very common in patients with acute coronary syndrome. So they should be treated with the arrhythmia-specific guidelines. This is a normal ECG. Here you can see all the leads, whether the limb leads or the chest lead, are normal. They do not have any ST segment elevation. As compared to this another ECG, just showing simple ST segment elevation, I am sure that any MBBS student would be able to diagnose this ST segment elevation myocardial infarction just by looking at this elevation of the ST segment. And why this is important? Because our country, many of their places are the primary health centers where the cardiologist, what to talk about cardiologist, even MD may be not available. And these patients, if they are given at these centers thrombolytic therapy, it can be life-saving and heart-saving. In patient with ST segment, non-ST segment elevation myocardial infarction, as compared to this, there may be just T-wave inversions along with the development of chest pain, which may normalize subsequently. So thus, it is very important and very easy to diagnose the major causes of acute coronary syndrome by this. This is another ECG which shows that these limb leads like 2, 3, and AVF, you can see that there is ST segment depression. Not only it helps to diagnose this condition of acute coronary syndrome, but it also helps to diagnose which coronary artery has got blocked. Because if you have ST segment depression or ST segment elevation only in 2, 3 AVF, it may be right coronary artery or the circumflex artery. Like in this patient, ST segment depression is seen in lead 2, 3 and AVF, and V5, V6 on the lateral wall. So inferior and lateral wall is affected. Maybe circumflex artery is involved, or a right dominant artery is occluded, which is causing these types of symptoms. So this another type of this. Can you make it further? Another ECG I will be showing you subsequently. Just you can see there's only T-wave inversions. These are very typical of the non-ST segment elevation myocardial infarction. And you can see here that where is the T-wave inversions? This is in lead V1, V2, V3, V4, V5. This is anterior part of the left ventricle. That is, it suggests that left anterior descending coronary artery is involved in this patient of development. So before taking up the patient for any angiography, just by looking at the ECG, you can diagnose which coronary artery may be involved in these patients. However, as I said initially itself, sometimes ECG may not be diagnostic, and patient with typical symptoms of acute coronary syndrome, chest pain suggestive of acute coronary syndrome, ECG should be repeated because it can be normal about 20% of these patients. So if the patient is having chest pain, do keep the patient in observation and do a repeat ECG as well as enzymes in those patients who have typical symptom but not ECG. Another very important tool which is now available at most of the hospitals is echocardiography, which is also should be there in most of the emergencies, because it is not only helpful in diagnosis of acute coronary syndrome, but is also very helpful in diagnosis of other causes of acute chest pain, like pulmonary embolism, like acute dissection of aorta, can be very easily diagnosed with the help of echocardiography. And those patients, the ventricular function, which is a major determinant of the prognosis of these patients, can be convincingly seen with just by putting a probe on the chest. Any physician can diagnose the left ventricular function of that patient. Similarly, the chest X-ray, which is available at most of the centers, is also helpful in identifying important conditions like pneumonia, pneumothorax, pleural effusions, or there may be, in patient with aortic dissection, there may be widening of the mediastinum. So these can be easily diagnosed. So these patients should also have a chest X-ray. Just a simple chest X-ray like in this patient with acute chest pain showed that this patient was having pneumonia. The diagnosis and management would be subsequently discussed with by Professor Kilani. Another important investigation is cardiac enzymes. The blood levels rise after 2 to 6 hours of the damage of the myocardium. So first changes that occurs is with the ECG. Later on, the cardiac enzymes are also diagnostic. Most of the patients present to hospital late in our country, and so these enzymes are also very helpful and are essential part of investigation of these patients with acute chest pain. They progressively increase and peak about 12 to 20 hours. The commonly done cardiac troponins are called troponin I and troponin T, but the CK-MB enzymes is also very helpful, but particularly progressive increase in CK enzymes is diagnostic of acute myocardial infarction. In those patients who have acute coronary syndrome, the enzyme should be repeated within 6 to 8 hours. This also should be remembered. One set of sample is not enough. So it should be repeated after 6 to 8 hours to see the progressive increase in the cardiac enzymes. Coming on to the diagnosis of acute myocardial infarction, as I said, the clinical symptoms are very important. The rise and further fall of troponins or CK-MB is important. Then the ECG changes. What are the ECG changes? That ST segment elevation of more than 0.2 millivolts in lead, any of the contiguous leads, V1, V3, or inferior leads, or is diagnostic of ST segment elevation myocardial infarction. The presence of Q wave suggests that this patient would have suffered acute myocardial infarction earlier. So this is also very important to remember so what should we do? We establish a rapid diagnosis of this patient presenting with acute coronary syndrome. These patients can often present with acute arrhythmias because the first, as I said, first hour is the most dangerous hours, and most of the arrhythmias occur during that time, particularly ventricular tachycardia and ventricular fibrillation and cardiac arrest. These can be managed by immediately recognizing and treating these conditions according to the guidelines. Importantly, these patients have crushing, severe chest pain. They are writhing with the chest pain. So prompt pain relief is very important in these patients. By particularly, as I would be showing you, morphine is the drug which is commonly used. 1 to 2 milligram morphine is used in these patients. In those patients who have hypoxemia, oxygen inhalation is given. But if these patients are not having low oxygen concentration by peripheral oxygen measurement, then these patients do not require oxygen. All patients do not require oxygen supplementation. That is also important to remember. The reperfusion therapy is very important. After you are diagnosed, this patient is having acute myocardial infarction. The reperfusion is important. The mode of reperfusion can be decided by the type of treatment that is available at that particular place or particular hospital. Whether it is a thrombolytic therapy or primary angioplasty, that can be decided by that. Treatment of complications of acute myocardial infarction, which is congestive heart failure, arrhythmias, or heart blocks, is also very important. So the patients, the urgent management should not wait for the biomarkers. ECG is most often helpful in these patients, but in those patients who do not have ECG features, like patient with left bundle branch block may not have typical ECG features, and these are the points which I can tell you in the next presentation. But for the time being, the patient with LBB and have certain features which in the ECG which help us to diagnose this patient having myocardial infarction. It is important to diagnose myocardial infarction early, as I said, because if you diagnose these patients, the diagnosis, if you diagnose within the first hour, most of the patient can be saved and mortality can be reduced to very minimal mortality. But if the damage, if the delay is there, then most of the myocardium has got damage, and the reversal of the myocardial damage does not occur even after initiating reperfusion therapy after more than 12 to 24 hours. Any angioplasty, bypass surgery, or any of the reperfusion therapy is not effective in salvaging the myocardium. So once you diagnose acute coronary syndrome, differentiate whether there is ST segment elevation myocardial infarction or non-ST segment elevation myocardial infarction. In those patients who have ST segment elevation myocardial infarction, or the antiplatelet therapy and heparin is given in these patients. Also, statins are given in the high dose statins of 80 milligram or atorvastatin is given immediately to these patients, and these patients are taken for either thrombolytic therapy or primary coronary angioplasty in these patients if the facility is available, because the reperfusion rate of primary angioplasty is much better than thrombolytic therapy. But in centers where the angioplasty facilities are not available, particularly like our district hospitals or the peripheral centers, the thrombolytic therapy should be given to these patients immediately, and then patients should be transported to a center where the further management can be done by percutaneous interventions. However, those patients with non-ST segment elevation myocardial infarction, remember, they should not be given the thrombolytic therapy. They have to be given antiplatelet therapy, anti-ischemic therapy, nitrates, beta blockers, calcium channel blockers, and anticoagulant therapy, but not the thrombolytic therapy. This is very important to remember. Those patients who do not have ST segment, again and again, I am emphasizing this point. So what is the treatment for unstable angina, non-ST segment elevation myocardial infarction? Besides bed rest, ECG monitoring, oxygen, and nitroglycerin by either infusion or orally, beta blockers are also very effective. These patients are also given antiplatelet therapy in the form of aspirin, and those patients who are hypersensitive to aspirin, clopidogrel is given to these patients. Anticoagulant therapy by the unfractionated heparin or the low molecular weight heparin is given to these patients. Also, the lipid lowering treatment is also very important in these subgroup of patients. This patient with unstable angina, after giving them these medicines, particularly like the anti-anginals, the antiplatelet drugs, if they continue to have symptoms or the ECG changes, then these patients are taken for early angiography. And often in those patients with unstable angina and non-ST segment elevation myocardial infarction, we see a subcritical stenosis of the coronary artery. Like you are seeing, this is the left main coronary artery. This is the left anterior descending coronary artery. This is the diagonal branch. And you can see here there is critical more than 90% stenosis of the branch. And after balloon angioplasty and most of the time stent implantation is also required in these patients, the perfusion can be normalized. Immediately the chest pain is relieved and myocardium gets salvaged. So early diagnosis of these conditions is also very important. Coming on to briefly the management of acute myocardial infarction, as I said, morphine intravenously is given in the dose of 1 to 2 milligram IV. Maximum dose is 10 to 50 milligram in adults. It should be 1 to 2 milligram IV should be repeated at the interval of 5 minutes and till the pain is relieved. Aspirin is given in the dose of 160 to 325 milligram. A soluble aspirin or chewable aspirin is given. As I said, if the patient is allergic to aspirin, then clopidogrel 300 milligram is given. And after this, it is important to open the occluded artery. Occluded artery, how to open? Thrombolytic therapy is given. And most of the time now, fibrin-specific agents are used because they have a higher reperfusion rate and lower complications by giving just a bolus dose of thrombolytic therapy, and the perfusion rate is also better. In those places like the urban areas where the management by primary angioplasty is available, primary percutaneous intervention by balloon angioplasty is done, and rapidly the patient can be reperfused and the perfusion to the myocardium can be restored. These patients, as I said, can develop ventricular tachycardia, ventricular fibrillation, and may require cardioversion. Those patients who have developed heart blocks, particularly complete heart block, may require pacing. So these are also required in many of these subset of patients. The defibrillators should be available at all the emergencies where these patients present and can be life-saving. Control of heart failure, shock, and hypotension can be done in the coronary care units. The statin should be given immediately. 80 milligram of atorvastatin should be given to these patients with acute coronary syndrome, even if they are taking the statins earlier. So, as I said, first hour is the golden hour. Maximum life can be saved by diagnosing and treating in the first hour. And if the diagnosis is delayed and treatment is delayed, then the little myocardium can be salvaged and many of the lives can be lost. So what are the guidelines about the management of acute myocardial infarction? As soon as the patient develops symptoms onset of chest pain suggestive of acute myocardial infarction. So symptoms of chest pain are very important to recognize. Immediately call an ambulance services, which should be dispatched within 1 minute, and emergency services should reach the person as early as possible in our country, but the guideline says within 8 minutes it should reach the patient. And while the patient is being transported in the ambulance, the ECG should be done in the ambulance itself. And if the paramedic is capable or a doctor is accompanying, then fibrillatory therapy should be given in the ambulance itself, because the time lost during transportation is it helps to minimize the damage. Also, it helps to better open the coronary arteries. If a person reaches a center which is not angioplasty capable, the PCI is angioplasty capable, then fibrillatory therapy should be given. As soon as the patient comes, the door to needle time should be less than 30 minutes. The time, as soon as the patient reaches emergency, within next 10 minutes, ECG should be done. That is what the guideline says. And within next 30 minutes, the thrombolytic therapy should be given to that patient. If a center is capable of doing angioplasty, the pain to balloon time should be less than 90 minutes. That is what should be aimed at. And total ischemic time should be less than 1 to 20 minutes. Those patients who are given fibrinolytic therapy, but fibrinolytic therapy is not effective, then these patients are taken for angioplasty, that is called rescue angioplasty. That is by percutaneous intervention of patients having multiple vessel disease or left main disease, then bypass surgery may be given to these patients. This is important. This slide gives the importance of that time is very important in management of acute myocardial infarction, because what it shows is that as the coronary artery gets occluded because of the thrombus formation, if you are able to remove the thrombus and reperfuse the flow, the artery can become normal and the damage to myocardium can be prevented. So more time is muscle and time is life in this condition. This is the patient who presented to us in the emergency department with acute chest pain. You can see there is ST segment elevation in 2, 3, and AVF. As I said, this suggests that this patient is having inferior wall myocardial infarction, which is usually caused by right coronary artery or circumflex artery. Here, the right coronary artery was involved, totally occluded. As soon as the wire and balloon angioplasty was done, not only the patient gave immediate relief from chest pain, but the ST segment settled within minutes. And this slide I'm showing just to emphasize that this PCI is very effective in the management of acute patients. Just in the last, I would like to summarize few of the conditions which are life-threatening, particularly like aortic dissection, which has a tearing chest pain, particularly in the back. And these patients, particularly who are having severe hypertension or connective tissue disorders, are prone to develop these aortic dissections. And pulse between the two arms, hypertension, these are the features which helps to diagnose these patients. On chest X-ray, widening mediastinum, echocardiography is very helpful in diagnosis of acute dissection. I would not be going into management of these conditions because of the paucity of the time. This is in a chest X-ray. You can see the mediastinum is widened. So this suggests that this patient is having, maybe having aortic dissection, which was confirmed on CT. You can see a false channel and a true channel, which gives the diagnosis. The CT scan is more in the centers where it is available, is used for triple diagnosis. Diagnosis of acute myocardial infarction, pulmonary embolism, and aortic dissection, which are the commonest cause of acute chest pain, particularly in the Western centers where it is easily available. Another important condition I'm going to just briefly say is pericarditis, which can cause severe chest pain. Most of the time it is viral pericarditis and maybe having flu-like syndrome in these patients. The pleuritic chest pain, which is having a sharp character along with respiration or with, it can be helped relieved by sitting or leaning forward, helps to diagnose this patient is having pericarditis. Pericarditis, typical friction rub may be heard in these patients, and there may be some pericardial effusion on the echocardiogram, and ECG changes of widespread ST segment elevation. As I said, you can see here wide said there's all the leads, maybe inferior leads, maybe anterior leads, all the leads are showing ST segment elevation with the concavity upwards. So this suggests that this patient is having pericarditis. Important to diagnose because these should not be given thrombolytic therapy. Just to conclude, dear friends, there are few of the summarizing what I have presented in last half an hour. A meticulous history is very important in diagnosis of acute chest pain, and angina is the diagnosis by history. So careful history helps to diagnose not only angina, but helps to diagnose acute chest pain, which may not be diagnosed by other investigation initially. Later on, it can certainly be diagnosed. Those also important to remember the life-threatening cause of acute chest pain, that is, besides acute coronary syndrome, aortic dissection, pulmonary embolism, and pneumothorax can also cause severe chest pain. ECG is very helpful in diagnostic of ST segment elevation myocardial infarction. Once it is diagnosed, immediately reperfusion should be done, whether by thrombolytic therapy or primary PCI, whatever is available at that particular place, and should be given to that patient. The plaque disruption, as I said, is the cause of thrombosis causing acute coronary syndrome, ST segment elevation, non-ST segment elevation myocardial infarction, or unstable angina. So emergency primary PCI is the preferred strategy for management of acute ST segment elevation myocardial infarction. But if this is not available, then thrombolytic therapy, preferably with a fibrinogen specific agent, should be given. The antiplatelet drugs and antithrombin drugs also help to improve the outcome because there is formation of clot, because there is deposition of platelets, thrombin formation. So all these therapy are very effective. The death and MI and refractory angina can be reduced by the use of intervention therapy if it is available, or if after thrombolytic therapy, patient can be shifted to a center where these can be given. The patient can be free from recurrent development of acute myocardial infarction. Thank you very much for your patient listening.
Thank you, Professor Tyagi, for an elaborate, eloquent deliverance of this lecture. I have, before we open it up for the questions, we are looking forward to it. I think it has been a complete revision for me as a pulmonary critical care person. I had a couple of queries which were coming to my mind, and because we are teaching undergraduate, you have been so they have been asking about what is the role and what point of time is we should use highly specific troponin. That is one part. And the CPK-MB, what has it got today any role in terms of diagnosis of a pain chest? That's a question number one, sir.
As soon as the patient presents with symptoms of acute coronary syndrome, or this patient should be the high sensitivity troponin is now preferred in most of these patients. And second enzyme, that is the CK-MB. But important that I would like to emphasize, as in given the latest guidelines also, increasing the progressive increase in these enzymes is more diagnostic of the myocardial damage, as has been shown that sometimes the CPK-MB may be increased in some patient with chronic renal failure, or maybe after some muscle damage after trauma. So these are not absolutely specific, but rising titer is absolutely specific of myocardial damage. So take the blood sample immediately the patient presents to you, and repeat a sample after 6 hours and then after 12 hours would be very useful.
Similarly, sir, a lot of people have been confusing actually pain chest, especially non-specific, with the heartburn, because that is very common problem which we encounter in general practice. So what will be the tips you would like to give to our audience in terms of differentiating between classical anginal pain or ischemic pain vis-a-vis which happens because of heartburn? Because that is again a very common issue which have come, and one has seen disasters happening because of failure to identify them.
You're absolutely right. I think not only medicos, but the patients also often confused with these peptic pains or even GI pains. And the important thing to remember is that these patients often have a constricted type of pain. The pain is usually a compression type of feeling and is persistent, and often the transmission of the pain to the jaw or left arm, and these patients particularly having sweating. So this is suggestive of the myocardial infarction pain. But similarly, angina pain is very typical. It occurs on exertion, like if the patient walks on level ground, he is not having chest pain. But if he climbs stairs, that he is chest pain. And as soon as he relieves, as soon as he sits down, the patient gets pain relief. So these are very typical features of angina. So these can be easily help to distinguish patient from the gastric pain. But even if you have diagnostic dilemma, whether it is a chest pain due to gastric condition or due to the cardiac, I would say, and guidelines also say, that do an ECG immediately. Simple, not an expensive test, helps to diagnose this condition very effectively, whether it is a patient or a medico. Just a rule out, just to very high, if the patient during chest pain is not having ECG changes, so we can to a reasonable certainty say that this patient is having non-ischemic pain. Many of the times, however, as I said earlier itself, I have seen also in my practice that about 20% of the patient with chest pain may have non-diagnostic ECG initially, but in subsequent hours they may develop myocardial infarction and may die. So if the patient is having typical pain, keep him in your clinic or in your nursing home or in your hospital or in the emergency department, and do a repeat ECG and enzymes, which is very important.
The reason asking is because in esophageal spasm, nitroglycerin is also very effective. So one has seen disasters happening. So at what point of time you will suggest at what frequency we should do ECG when we keep them in emergency room to know and can be safe this is not likely to be a coronary?
See, immediately as soon as the patient presents to the emergency department, and maybe repeat within next 30 minutes to 1 hour, and maybe after 2 hours, a very inexpensive test, and just put the patient on monitor and do a repeated ECGs, which are very, because patient, if you are able to diagnose the ST segment elevation myocardium infarction while it is occurring, the total salvage of myocardium can occur. So, inexpensive test at your bedside, which is available in ECG, which is available at most of the places in our country. Repeated ECG should be done after half an hour, 1 hour, as early as possible. If it is a busy center, and particularly I would say if the chest pain is typical, treat it as acute coronary syndrome.
Because what you are saying, sir, it reminds me of Professor Lowndes when he has written very clearly and eloquently that if somebody points out a finger to a place of pain, it is unlikely to be coronary. But if somebody is not able to tell it and it's very diffuse and
most of the time patient presents like this, I'm having chest pain like this. If the patient is having pointed chest pain, then it is costochondritis or muscular pain. They're very easily to diagnose. And particularly if a young female presents with pain, with pointing finger, I am having pain below my breast, or for last 2 weeks I am having pain at this time, you can easily say that this patient is having non-cardiac chest pain.
So this brings to my next question, sir, to you, as in the sec. How to diagnose coronary artery disease in premenopausal females? Because that's something one has seen again, challenges coming up with the diagnosis of a young woman, especially of acute pain chest when they come up.
Absolutely true, sir. All of us should remember that menopause or no menopause, now that theory is gone. And we have seen in our hospital, GV Pant Hospital, one was senior resident between 20 to 30 years of age, developed acute myocardial infarction in the hospital. So do not go by premenopausal, postmenopausal. Particularly it is very important because most of the times these may have some atypical symptoms. They may not have, as you said, typical symptoms of severe chest pain radiating to left arm or jaw. Thus, they may, in particular in the females. So a high index of suspicion should be there in these patients, and they also should get the same priority as given to the male counterparts. Even if the ECG is turned out to be non-diagnostic, maybe if the patient is not having angina or myocardial infarction, I would be very happy to do repeated ECG in these patients and to tell them or do the enzyme test that now I can safely send you home.
Thank you so much, sir. And it also adds to us. We have also two young, one doctor and another one. They were on oral contraceptives, turning out to be massive pulmonary embolism. Therefore, yes, it's not only that we are looking at a coronary when we are looking at a pain chest. The history of oral contraceptive in young women is extremely important. That's what we are seeing. And we could timely give them thrombolysis and save them. But yes, they came in a hypotension shock. And final question, sir, before I open it up quickly is what do you say is the role of point of care ultrasound? Because in emergencies it is being used now. Echocardiography is one part, but it can help us the way we are looking in critical care in making differential diagnosis of pain chest.
Absolutely. I think it's an essential tool. And now I think it's a part of stethoscope, and soon we will be having stethoscope in echocardiograph. So it's like a clinical examination to me, and it should be available at most of the places where even putting a simple type of echocardiogram, just putting a probe helps us to diagnose whether this is having wall motion abnormality or not. The ventricular contractility is normal. We can be very sure this patient is not having any serious type of chest pain or acute coronary syndrome.
In fact, sir, we are using very extensively now in intensive cares actually to diagnose pericardial effusions, pulmonary embolisms, and also pneumothorax, pneumonias, and other cardiac and respiratory conditions, and also making a diagnosis of shock.
Maybe more helpful than the stethoscope.
Yeah, that's true. It's becoming. With this, I request, because I have not seen any question in the chat box, that's why I have been discussing it. I will request my esteemed gathering and colleagues, if they have any queries, etc. Today we have a really golden opportunity to clear our doubts also. So my request to any of the participants, to if any questions around, to request.
Dr. Dhruv, can I ask one question?
Yeah, Dr. Chabda, please.
Yeah.
Good evening.
This is a very nice presentation. But I would like to, as you say, the echocardiography, even nowadays we should use the probe to see the exact diagnosis with the echocardiography. But there are sometimes there is legal problems to do the echocardiography. PTD and the Act and all that. Echocardiography is very, very important tool to diagnose any chest pain or any cardiac problem.
The legal problems are before getting echocardiography machine. If you have an echocardiography machine, there are no legal problems. And if the PNDT, you have done your PNDT filling of forms and you have echocardiography machine, so don't be afraid of legal problems. And don't be afraid in a patient of acute chest pain to defend yourself in diagnosing these patients with the echocardiogram.
Dr. Tyagi, you are rightly said, but very हम कहते तो यहाँ तो बहुत कहते भी कुछ अपडेट करनी, लेकिन क्लर्क लोग इतना तंग करते हैं मशीन के चक्करों में, बता नहीं सकता आपको सर.
नहीं, आपने बिल्कुल
At the
ठीक
bench.
कहा, आपने
Dr.
बिल्कुल ठीक कहा।
Chabra, I think this is something which probably is beyond
Yes.
this. But nevertheless, I think I will simply say that is what is very important is, like
Yeah.
all of us are having a flux of residents each year. So what
Yes.
we do, those who go away, take their name away. Those who come up, we put their name away and take the responsibility and things. Yeah. I think we will not discuss it beyond this point because
Yeah.
it's not related with the topic, but this is in a general, you are very right in the environment in which we are working. And we have to take care of the legal environment.
Yes.
Okay, I have a question regarding the low molecular heparin. Dr. Ashok Das here.
Yes, Dr. Das, please.
Professor, the role of low molecular heparin, Professor Tyagi.
I think it has very eminent role, not only in unstable angina, non-ST segment elevation myocardial infarction, but even in those patients who are being given thrombolytic therapy on follow-up also, because there may be recurrence of thrombosis. So nowadays recommendations say that give them unfractionated heparin or low molecular weight heparin in these patients after giving thrombolytic therapy to these patients. But patient with unstable angina, non-ST segment elevation myocardial infarction, the unfractionated heparin have been very useful and quite safe in the management of these patients, can be given easily at the centers while to prevent the development of total occlusion. It was a very important point raised by Professor Das.
Thank you.
If you have any question.
Last question, 1 minute, sir. Talk about the chest pain. I just have a question regarding silent MI, just to clear the doubts, because a lot of people get silent MI in my specialty and others. Just to highlight it, sir.
So, particularly elderly patients and those patients who are diabetic, 20 to 25% of these patients, even females, sometimes develop silent myocardial infarction. But these patients sometimes have atypical symptoms. Symptoms like just they may be having some ghabrahat or sweating. And it is important, even if these patients have, I think, better to do an ECG and rule out myocardial in the acute coronary syndrome rather than delay the diagnosis. So those patients should be more and more diagnosed. And those patients particularly having in elderly age group of patients, those patients who are having other cardiac risk factors like diabetic patients should be having very high index of suspicion for diagnosing, even if they have silent acute coronary syndromes.
So there are two questions which are there in the chat box. One is in terms of thrombolysis, because what I could make it out from the cartoon which you had presented and the flow sheets which have been there, that means that anybody has got more than 30 minutes of picking up the call and reaching to the hospital with the PCI facility. If it is more than that, should they all be thrombolized? And the question in the chat box is, tomorrow, let's say we are moving in the traffic of Delhi and the reaching time may be more than 1 hour. Should they all be getting thrombolysis before reaching the center?
I think very appropriate question. I think not only in India, not only city of Delhi, but any city of the country or even world abroad, even while you are US or European countries, there may be delays in the management of these patients, and pharmaco-invasive approach has been shown to save lives. This is the pharmaco-invasive approach, initially giving thrombolytic therapy and then followed by angioplasty if there is no regression of the ST segment elevation. These can be life-saving and in these patients. And nowadays, as I had shown, and because of the paucity of time and briefity of the topic, I have not presented. What we recommend is that ambulances should be equipped with the help of ECG, and ECG should be transmitted to a center where the diagnosis can be done. And whatever paramedic or doctor is there, after confirmation of diagnosis, thrombolytic therapy should be given in the ambulances while the patient is transported. But like city of Delhi, 1 hour you take to reach the hospital. So that 1 hour is very, very crucial.
So I will say that there is a golden hour in which we need to act, whether we interact through the percutaneous intervention or through a pharmacological therapy in terms of...
Yes. Pharmacological therapy is very useful and effective.
Thank you so much, sir.
Tyagi, sir, one question from my side, sir.
Pardon, sir. I think we have to shift to the second talk. If you permit. Yes.
Okay, sir, will not take more than 10 seconds, sir.
Okay, please.
Shall I, sir?
Yeah, please.
Sir Tyagi sir, what is your message for the doctors who are working in the peripheral settings as PHC and where the availability of the ECG machine is also not there? So the patient who is coming for the typical of the chest pain, the giving the symptoms of the coronary involvement. So what's the message for them from you, sir?
Give them antiplatelet drug, that is aspirin, 1 full tablet dissolved in water, and shift the patient whatever mode of transport is available. If ambulance is not available, don't wait for ambulance. Any mode of therapy transport is available. Shift them to a center where thrombolytic therapy can be given after giving antiplatelet drug.
Thank you, sir. Thank you so much, Professor Tyagi. I think you need to give big hand to him.
Thank you, sir. Thank you.
Thank you, sir. Thank you very much.
Sir, namaskar. Sir, namaskar.